We're here to present 5 myths of concussion and what you need to know to recover. And I'm Dr. Joe Schneider. I'm a chiropractor. I am a postdoctorate in neurology, and I'm a fellow in the National Academy of Functional Neurology. I am getting my fellowship in traumatic brain injury and vestibular disorders, and I will complete that next spring. I'm executive director of the Brain Balance Springfield and Cherry Hill. We have a second office in Cherry Hill, Back and Neck Pain Relief Center, and the Brain Recovery Institute. Why is this so important? Why it's so important is that recovery from concussion is usually not complete. So the medical model that we've been using for recovery from mild traumatic brain injury is not working. So kids are left, and adults are left with residuals that affect their life in many ways. And then if they have multiple concussions, then their problems increase over time. So your son could have had some kind of concussion from athletics or something like that previously, had the auto accident, and would have made it much worse for him. Okay. So in a concussion, what happens? It's a mild traumatic brain injury. So an injury of any kind causes inflammation in the brain. So fibers, nerve fibers, are broken and die, and connections are broken and they lessen. So what we want to do is we want to dispel the myths of what a concussion is. So when you have a concussion, the individual is in a state of emergency. So we want you to come away with a full understanding of what a concussion is, what is it affecting, who is it affecting, and how we can get people with concussions to have a full recovery. So traumatic brain injuries, it's compelling. Statistics say that there's 1.7 million concussions every year. Causes, auto accidents, falls, sports, assaults. Loss of productivity is 76.5 million. But the worst part of it is it takes the life away of a person who has a traumatic brain injury. We've had several cases now that we've had through Brain Balance, and we've actually have put their lives back together, back on course. One of our cases, he's a sophomore in high school and didn't look like he would complete high school at all. He was in 8th grade, an exceptional student, honor roll, so forth. And when we went to the school meetings, they said, well, maybe he was just average intelligence back then. And maybe he was just average in everything. And the mother spoke up and she says, well, did you just lie to me? You did all these assessments, you just lied to me. They didn't know what to do with him. So his number one symptom was headache every day. And couldn't go to school, couldn't function, couldn't do anything, gained weight. And they were just worried that he would not graduate high school. We've worked with him for about 6 months, and he's going to start normal school in September. So we can take kids or adults with concussion, analyze them, and bring them back from where they were by doing specific tests to their nervous system to find out where the weaknesses are. So the harder the impact, the worse the concussion, that's a myth. Football players, well, football is number one for concussions. Boxers, and then soccer players. Women's soccer is actually second to football in concussions. But with soccer players, what you do is you get repetitive concussions from heading the ball. So one concussion after another. They may practice, head the ball 100 times a day, get micro concussions to the brain, and then they're playing in a championship game and they might have one great header and they scored the winning goal, and that's the one that takes them out, okay? And then all their function starts to decrease. So any injury to the brain or any force to the brain will cause you to have a concussion or an inflammation of the brain in certain areas. So the severity of concussion has less to do with the degree of impact and more to do with location of injury, whether it's in the front of the head. How many previous concussions did you have? And the younger the individual, the worse the concussions usually are with less force. You hear about shaking baby syndrome and so forth. So severity of concussion is not about impact, it's about loss of function. So we want to measure function. So we're going to keep talking about that over and over and over again. If we do not measure function, then we cannot define the seriousness or the degree of concussion. Myth 2, it's only a concussion if you lose consciousness. You only lose consciousness in about 10% of concussions. A person can lose consciousness for a few minutes, for hours. It could be for up to 24 hours. So in your case, during the auto accident, did your son lose consciousness?
No, he did not.
He
And
did
that's
not.
one of the reasons the insurance company is saying it's not.
It's not a concussion, right, exactly. And that's because the functional analysis done on automobile accidents is just not there. They'll say he had a whiplash injury, which is a soft tissue injury to his neck, and they'll ignore the concomitant inflammation and trauma that goes along with the brain. Concussions are only caused by blows to the head. Concussions can occur by any transfer of force to the brain. Examples include whiplash, an impact to the face, and a twisting of the head in a helmet. Now, if you think about a concussion and you think about the brain, okay, the worst part is a twisting motion of the head. So if you're looking at the brain and the spinal cord and the midbrain, what happens in the rotational aspect, you twist in the midbrain area. So concussions can be caused by a rotation of the head, even in a whiplash, even a shaking injury, okay? It can go either way. It can be a lateral type movement to the head, where the head is on the stick of the brainstem, and it can go both ways. Now the cortex could be fine, but the brainstem always gets injured. So even with an impact to the face or a fall to the face can cause whiplash. Injuries to the jaw can cause whiplash injuries to the neck, but also concussive forces to the brain. And if you think about it, the structure of the brain and the nerves are pliable, and they're sensitive to any forces that may happen there. So anytime you apply a blow to the head, or a force, or a rotational aspect to the head, those structures are not pliable anymore, okay? They are hurt, they're inflamed, and they cause destruction over time. You know right away if someone sustained a concussion. Symptoms of concussion may not be immediate. You're not going to see them right away. So you get in a car accident, your brain can be shaken up, and then you leave the site of the accident, you say, okay, I'm all right, I go to the emergency room, they release you, you do a CAT scan says everything's negative, there's nothing going on in the brain, and it's like, okay, you didn't have a concussion. But then slowly things start to happen. Your sleep cycles get affected. They start getting headaches. They start getting emotional type issues or anxiety, depression. They have difficulty with computers and televisions. They have difficulty with driving because their vision doesn't operate right. They can't go into a room in which there's many people and be able to sustain that through the conversations and filter out things like they used to. So symptoms of concussion may not be immediately felt by the individual or noticed by others. They may take minutes, hours, even days, even weeks, or even months to fully manifest themselves. So the idea that we rest for 4 weeks, we measure them in 4 weeks, and we say whether they had a concussion or not, we put them back into all their activities is destructive. It really is destructive. We need to keep measuring people who've had concussions over time. So the effects of concussions are short-term. Truth, some symptoms such as nausea, dizziness, headaches, and confusion may disappear in hours or days. However, long-term effects may include. All right, so let's say effects of concussion are short-term. No. What we don't do is we don't measure over time the appearance of symptoms that may take time to appear, okay? So they may wake up in the morning and they may not have a concussion symptom, but then hours later, after they're into their day, their brain stability goes down and they can't sustain themselves throughout the day. They're like, I don't know what's wrong with myself. I felt okay at 8 o'clock, but now I can't function. I can't do anything. Or their stamina is affected, so they can do something for a little while, but then they back off. So what they do is they'll have memory issues, depressive effects, because they affect the emotional centers of the brain. Other changes in mental status, like can they process information? Can they read and comprehend like they used to? Short-term memory versus long-term memory. Is that happening? Increased susceptibility to additional concussions. Once you've had a concussion, all you have to do is get a little hit, and it makes it worse. You see it so much with hockey players that they get a concussion, they don't really talk about it, then they go out on the ice and they get a little hit in the jaw and they're down and out completely. And then what happens with families and friends will say, that was a nothing hit, what's he doing? Is he faking it? You know what I mean? Motivate him a little bit, get him in there, pat him on the back, something's going to happen. So a survey was conducted by 120 high school athletes that asked questions related to concussions in sports. The majority responded that they understood that headaches, dizziness, difficulty with memory, difficulty concentrating, and light and sound sensitivity were all risks for concussion after a high-impact hit. Although student athletes indicated they were aware of the risks associated with concussions, 53% of the players said they would always or sometimes continue to play with a headache sustained from an injury. However, only 54% of players said they would always or sometimes report symptoms of a concussion to their coach. I went to a conference at Villanova, and Brian Westbrook was there. And Brian Westbrook said he knew that he was playing for a concussion, with a concussion. He knew that on some plays, he would totally black out and come back to the huddle and get back in, because he was afraid that someone would take away his position. So over time, he disintegrated to a point in which every aspect of his life has been affected. He thought he would recover, but every aspect of his life was affected by that. And Brian Westbrook is probably one of my most favorite football players of all time. And he feels his life has been destroyed because of football. So from this chilling statistic, we can see that simply knowing the symptoms of concussion is not enough. Ignoring symptoms or trying to tough it out will only make symptoms worse. So we're at an IEP for a kid with concussion. We're trying to rehabilitate him, get him back to school. The neurologist calls and says, well, there's an injury phase, there's a recovery phase, and then there's a psychological phase. He's recovered fully. It's psychological now. All you have to do is motivate him to get out of bed in the morning and toughen through the headache. That's it, ignoring a symptom. That's ignoring exactly what's going on in the brain. And if you're a neurologist, you need to understand how the brain operates, not understand just how a drug operates. So ignoring symptoms or trying to tough it out only will make symptoms worse. Symptoms indicate a disruption in function within the brain. Rest alone will not lead to recovery of lost function. Functions within the brain derive from connections within the brain. So we know that if function is dependent upon connections, that we need to analyze the brain connections. And we have to do it in a comprehensive way, totally comprehensive. So if there's a 10% loss of function in 10 areas, different areas, that's no good for someone that was functioning really well before, okay? That creates confusion, fogginess, an inability to do what they used to do. It creates frustration. So if we're going to look at concussions, we have to look at connections in the brain that are damaged or disrupted, because that's what a concussion is. That's what traumatic brain injury is. It's a loss of connections that are not restored on their own. So the only way to restore connections is to rebuild it. Now we know that the nervous system is plastic, okay? Every day our nervous system is plastic. So that means whatever we see, whatever we hear, whatever we do, however we move, we are changing our brains at all times, constantly. The brain has a metabolism that must be met also. So if we look at connections, we look at the wiring of the brain, we know that the only way to rebuild it is to look at it metabolically, to look at it as a functional unit, right? Not just say, okay, this balance is off or this is off, we'll just do that for now, and then later we'll do this, and then later we'll do that. Our nervous system doesn't do that. Our nervous system is integrated at every moment of time, whether you're sleeping, whether you're moving during the day, whether you're learning anything, and it's plastic, constantly changing, okay? So an athlete who rests after an injury will not recover 100%. They must go through athletic training, stretching, weight training, cardio. They must treat the brain the same way and retrain it in an integrated way. So what we miss in the concussion recovery is that we don't retrain the brain in an integrated way, and we don't test every function so that we can create an integrated plan to do that. Now, the nervous system is not just dependent on vision, hearing, balance, body movements. It also processes that information, the body information, the sensory information. It also processes that, but also when it processes that, it uses information in different ways to learn, to behave, to socialize, okay? So you have to look at the nervous system from the bottom up, okay, into the brain. And to go to higher levels, you have to look at how they cognitively express themselves. So they may be able to read a lot, but they can't remember anything they read or comprehend it. They may remember details, but they don't remember the big picture. They may have short-term memory, but they don't have long-term memories, okay? So unless we start and we work the body functions along with cognitive aspects in the right way, we are not going to get full integration higher up. Now, once we do that, then there's behavior and socialization that needs to be worked on from the conclusions that the brain gets from the rest of your sensory inputs. So every sensory input in the body is dependent upon all the others for proper function. So we have a sensory input, it integrates in the brain, and then we have a motor output. Everything that we do is dependent upon what we see in the world, what we hear in the world, what we feel in the world, how we move in the world, and then everything controls a decision for motor output. So we can have motor output in muscles, we can have motor output in glands, digestive, respiratory. We can have the same thing in the thyroid, the adrenal gland, and so forth, and have proper coordination. But everything here is moving. We either move towards something, we move away from something, we move side to side away from something. So our bodies, in an evolution and development of our brain, is all about movement. And the brain is the great integrator. So if we do not stimulate and integrate, then we're not going to make the proper changes to the brain. Our decision-making ability is a result of higher level cognitive processing, reasoning, and how our brains use sensory motor input. Our brains are constantly learning at all times. So the more we do, the more we use our brain, the better it was. What was the study years ago about the nuns? Cloistered nuns. They did a study with cloistered nuns for years. And the study was that they cooked, they sewed, they gardened, they prayed, they meditated, they read, their life was integrated in so many ways, and they weren't dependent on television or screens or computers or anything else. And when they measured brain function after years, they found that when they got into old age, they didn't really lose a lot of function, and they were healthier for it. So they had really great decision-making skills. They had really great analysis and reasoning and so forth. And that was based on the multimodal type of activities that they performed every day. So we must be able to break down and process information around us in order to properly understand our environment. We had a student from St. Joe's Prep who got a concussion in wrestling. And when he finished the program, he wrote us a great testimonial. And the testimonial was basically, I think I'm better than I was before the concussion. Okay, so he got in, he had daze, he had confusion. I think if he didn't come in, he would have gone on a progressive downward slide. Junior in high school, you know, taking his SATs, getting into his senior year, wanting to go to college, and then he's feeling like, I can't do my schoolwork anymore, right? So for us, that was the best thing. You know what I mean? We not only did his physical types of losses, but we looked at his cognitive losses, and we were able to fine tune it so that he really did better in all those functions later on. So how are connections made? Well, what we look at brain balance for developmental disorders is we look at primitive reflexes. Primitive reflexes show that the brain has not matured. In a traumatic brain injury, I liken it to the brain takes away from maturity. That maturity that's been built over years has been lost, okay? So primitive reflexes might start to appear after a traumatic brain injury. And primitive reflexes are the oral reflex that you have when babies are looking for nipples. So you might have a reaction in the cheek to it. Palmar reflex. That's called the Rudy reflex. So don't look for Martha's correction. So you look at a palmar reflex. When you put your finger in a baby's hand, you get this type of response. So we look at all those reflexes. There's symmetrical reflexes from neck movement. There is reflexes that we get for startle, sound, right? Exactly. So all those primitive reflexes we look at the bottom level. How were they affected? And those, and with traumatic brain injury, with developmental disorders, we'll see that there's primitive reflexes that happen. So we must rebuild from the bottom up. Then you have postural reflexes that happen. Sensory gross motor core strength issues that happen. You'll see this, you know, kids that have really been athletic and they lose their core strength. It just kind of goes away. So that they have like a 5-year-old core strength. The one kid that lost school for 2 years and we got him back, he couldn't believe how bad he was in his core muscle strength. He lost, what, 40 pounds? 60 pounds. He lost 60 pounds. He looks really, really great. Really, really great. So you see that core strength is lost. Then fine motor movements. Then cognitive aspects are lost. Then academic issues start to happen. And then behavior starts to happen. So right now we have 2 concussions in the office right now. And actually they're older, 26-year-old and a 36-year-old. 36-year-old fell, then had 3 car accidents in 6 months and just totally wiped her life out. Couldn't work, just emotionally a wreck. And she just finished her first program. We're going to have her do another half program. And she's progressively getting where we want her to be.
Does she also have, you were referring to what your son had?
I missed the integrated amnesia, the interrogated amnesia.
But the sensory?
Oh, the synesthesia.
Synesthesia. She's got, I wouldn't say photophobia, but it's like.
She doesn't have photophobia, but she has hyperacoustic issues, where she's with many different people. It really affects her. She's starting to be able to go in a car a little bit better, less light sensitivity. Her sensory motor aspects are tremendously going away, except for the hyperacoustics. But we can talk about that part of it later. And then the other person had got hit in the back of the head with a brick when they were in 7th grade. And then over time, over years, everything got worse for her. Got worse and worse and worse for her. So concussion can get worse over years and not get better, okay? So we have to change that trajectory, okay? And so we have to divide it. So the most affected area is the midbrain. So the area that most affected in case of concussions is also the area that integrates every function in the brain, so the midbrain. It's the smallest region of the brain, and it acts as a relay station for auditory visual information, control of eye movement and body movement. But the idea is that there's always a rotational component. There's always a force like this that affects the midbrain more than any other aspect. So if you get a CAT scan, you're going to see that nothing's wrong, but they're dizzy and so forth. So how does the midbrain interact with everything? Well, you have something called the cerebellum. Have you ever heard of the cerebellum? It's for balance, coordination, and so forth. And then you have the pons in the middle of the midbrain. And what we have with the pons is we have our inner ear. So we have the semicircular canals that can actually be injured in a concussion. You have otoliths that measure translational movement, either forward, up, and down. And they integrate here in the pons. You have most of your cranial nerves that come out that will control your tongue and your throat for phonation and so forth. Does he have any phonation type of issues? Slur of speech or?
If he extends himself too much or gets any kind of blow to the head or whatever, he will have trouble both with slurred speech, slow speech, he's normally a very quick speaker, and word finding.
Word finding, right. So we're not connecting here to here, okay? So that's what happens. So in the phonetic centers into the prefrontal cortex, frontal cortex, coming down into the brainstem, those signals aren't as developed as we want them, okay? So you'll see that. Right here is what's called the reticular formation in the brainstem, and that's all our autonomic functions, our sweat glands, sweating of the hands,
Fight or flight.
right, fight or flight, peripheral neuropathy, respiration, cardiac function. It doesn't coordinate like it should. Digestive issues can happen, so forth and so on. So it really is the most important part of the assessment for concussions is the midbrain. It also, the nice thing about the midbrain is right up in here, we control our eye movements. The top of the midbrain, called the mesencephalon, is where we control eye movements and where it integrates sound. So our grid for sound, okay, is dependent on function in the upper midbrain. And our grid for vision is affected in the top of the midbrain. So we have grids. So I see you, and if you talk, and I close my eyes, I should know where you are in space after I see you. You see what I'm saying? And then when you talk, the sound should come exactly from what I saw, not over here or over there. So what happens is, in a concussion, the grids start to not match, whether it's visually, auditorily, or proprioceptively, where I know where my finger is,
Right.
and I'm pointing you, and then I close my eyes, and I can bring it up, and I can point to you again, even if it's a sound, and I know where it is. So I have that in memory. So that all happens up here in the mesencephalon. Now, the limbic system, right, is our emotional centers. So our emotional centers are subcortical. They're right on top of the brainstem. So secondary injury is to the subcortex, okay? So the subcortex is where the emotional centers are. And vision, auditory interconnect with the limbic areas, okay? So if your grids are off, you have confusion, you have emotional confusion, okay? So there are areas that have to be rebuilt, okay? We know how to do that. It also has a relay station for sensation called the thalamus. So all sensation are relayed to the proper places in the cortex. If the thalamus is injured, then we don't have proper relay, and we have more confusion cortically because we don't know where those sensations are really coming from anymore, okay? And then we have the basal ganglion. So you know what the basal ganglion is. Parkinson's disease, a person with Parkinson's will lose affect in their face. They'll lose emotion. So the basal ganglion is motor function to the face to express emotion, okay? And that interconnects with the limbic system. It also gives you smooth movement, okay? It's inhibitory towards movement. So a person with Parkinson's can't initiate movement, and they roll their fingers and so forth. They have like resting tremors and so forth. So you see that develop in a person with concussion, okay? They may not be able to initiate or get motivated to move. Or you may say that, okay, you have to go here, and they'll say, yeah, I will, but they really can't, you know what I mean? And they have that problem. That causes a lot of anxiety for them when they can't initiate or get motivated with movement. So the midbrain is a complex relay station that affects what goes on in the body versus what goes on in our upper cognitive and behavioral and executive function centers. So we have visual, auditory, vestibular, which is balance, inner ear function. All these systems in the midbrain must be properly working as a perfectly timed relay station for all information. So how do we rehabilitate it? Well, we integrate visual auditory stimulation simultaneously while also introducing motor and movement exercises. So the aspect of training myself for traumatic brain injury is that we've taken the visual system and we've had 4 weekends already, okay, just on the visual. We take one pathway and we work it and work it and work it so we know what all the interconnections are. So when we look at visual, we're looking at eye movements, right? And we have 6 muscles in each eye for eye movements. And there's a complex coordination from right to left. So if I look at my finger and look at my other finger, back and forth, it's called a saccade, right? It's a complex eye movement that takes into effect many different centers in the midbrain and the subcortex. And then there's smooth pursuit. Can I smoothly pursue something? Can my eye muscles coordinate that? Those things can be lost. Can I fixate? Do my eyes align? Do I do it really, really well? Or are there glitches in that system, okay? So you may say, okay, well, he looks like he's pretty good, but then when you really test it intimately, you start finding that there's glitches in those systems, and they're not working the way they should. And those systems have to come back for them to recover from concussion. If you look at vision and head movement, because if I walk, right, and I want to keep looking at you, well, I'm moving up and down. So my eyes have to react to what my inner ear is telling what's happening as far as movement is concerned, so that I can keep my focus on you. If I'm walking and I'm going like this, then there's glitches in the system. And those glitches don't provide proper integration for that person. If I look at another visual, I'm going to look at you, I'm going to turn my head. Okay, I can't look at you, all right? I have to be able to look at you. That's called a vestibular occlusive reflex, okay? If I want to look at a moving object, going back and forth, or if I'm driving a car and things are moving past me like this, that's called an optokinetic response. If my optokinetic system is not good, then I'm not going to be able to measure that, and I'm not going to be able to stick with the focus that I have. It's going to take me off. So we want to look at that type of integrated function with visual. Now, auditory is more grid aspect, but what we're finding about the auditory system is it is frequency dependent, okay? Certain frequencies will stimulate certain areas of the brain, okay? So you may have hyperacoustics, you might have low acoustics, right, that can drive a person crazy. But those frequency systems are not integrated the way we want to integrate. So if I just did visual, and I just did a few exercises in visual, and I didn't do them all, then they're not going to integrate. If I did visual and I didn't do auditory, then they're not going to integrate. So the only way to do it properly is to integrate visual and auditory stimulation with motor movements and exercises. So you can't stimulate one system. You must target each area in a specific way and make sure that it's integrated. So when someone enters our sensory motor room, we do 28 exercises in 30 minutes. Why they have color, why they have lights flashing, why they are hooked up to sensory stimulators. So that as they're going through, they're constantly integrating in different ways. Then we look at whether one hemisphere is stronger or hyper and the other one's weaker. And if we find that hemisphere, then we're going to stimulate in one to the weak hemisphere. So each stimulating exercise is a test for the body performance. So repetition and specific feedback to the brain makes it stronger. Okay? So by doing 28 exercises, then we talked about what do you lose in a concussion, traumatic brain injury? You lose wires, but you also lose more connections. So a nerve may have thousands of connections. After a brain trauma, it's down to hundreds. So the thing that grows in plasticity is interconnections. I can't give the nerves back. So those interconnections go from hundreds to thousands to tens of thousands that if it's integrated specific stimulation. Now each nerve sits here and they have temporal stimulation. That means one thing stimulates it and then raises to a threshold and says, okay, I'm going to tell something else. Okay? So you can do temporal stimulation, or you can do spatial stimulation from many areas, which stimulates this nerve more, makes it stronger, and makes it want to interconnect. So the plasticity that happens is, it's a plasticity of interconnections that happens. Now, what we said before was that the brain is totally plastic. Every day, our brain changes. Our brain is never the same ever again, right? So if the brain is always plastic and we give it the proper amount of stimulation in the proper sequence, what we're going to get is we're going to get a plastic system that goes to normal, right? That functions better. So with increased strength and performance, we increase the threshold. So that means we increase the amount of challenge that we give to a system. So when someone comes into our sensory motor room, we don't start them at the top level. We start them at the level they're at. And then as they build, we put them up to the next level of the protocol. And then we put them up to the next protocol. It's like baby steps. And as that system starts to integrate and get stronger, then it starts to normalize, okay? So certain things that would happen before don't happen anymore. They can do it. Our 36-year-old, when she started, she couldn't even get up on the balance beam. Now she can do the balance beam and she's throwing balls back and forth. She couldn't do interactive metronome, which is driving her crazy. Metronome beat, she's doing it, she's getting like right-ons now, okay? She couldn't stand on one foot. She couldn't do fine motor movements. So the first system for her to come back was her physical system. It's really strong. And if we keep the physical system strong, and we keep stimulating those systems in an integrated way, then higher areas are starting to come along. So the next area that we have kids or adults go into is the cognitive room. So they go in the cognitive room, and we look at how's their reading comprehension, how's their word reading, how's their vocal reading, how's their phonetics, how's their spelling, how's their math, how are they integrating their math in problem solving. So those are areas that we can fine tune. So they go into the cognitive room, and they start working on areas in cognitive function that aren't there. And once they start to function again, they start to improve. Now, what will happen is, once we get physical cognitive systems going, the emotional systems don't come along as quickly. But emotional systems are dependent upon learning. So you learn about emotions as you grow up, right? You're taught, okay? Someone's angry, someone's sad, appropriate times to be angry and sad, appropriate ways to behave. Well, when you get a traumatic brain injury, you lose that. You lose all those memories. You don't have them. So you don't have a basis. So those are areas that in certain situations, it's more situational. I put myself in the situation, I do something wrong, trial and error, and I learn, okay? And that's how you grow in those areas. So concussions must be measured individually for effects. There are no two concussive cases that are the same. You can't say he had a concussion, we'll just do this kind of rehab, because you miss out on all the beauty of all the other systems that have been lost. So effects are not always apparent at the time of concussion. All effects can be long-term. Each injury must be rehabilitated. All effects are long-term. They just are. If you injure your brain, it's a long-term effect. So your rehab must be individualized. It must be comprehensive, and it must be integrated. So the brain coordinates. We only rebuild properly through integrated stimulation and rebuilding. Exercises must be targeted and strategic in order to individualize treatment for each concussion. No recovery plan is the same. Sensory, motor, and building blocks for all higher level function needed for everyday life, cognitive, behavioral, and social processing. Because that's just the way it works. You know, it's like you want to put a diagnosis on it in a description, but the diagnosis is obvious. It's the obvious, right? I have a brain injury, I have a concussion. These are the effects. Okay, so what do? Well, we can medicate it, right? Medication is not going to rebuild a pathway, right? We can rest, okay? We can talk about it all we want, but it doesn't rehabilitate a pathway. So the only way to rehabilitate a pathway is through specific time stimulation that creates that aspect. Now, we talked about the physical aspect, we talked about the cognitive aspect, and the last part is the metabolic, okay? Your brain changes metabolically. And the reason is that supportive cells in the brain, like microglia will come in, and they're supposed to clean out all the inflammatory components. They're the cleaning mechanism. In concussions or brain injuries that are long-term and long-lasting, they are hypersensitized. They do too much. They're destructive. They give you headaches over long-term, okay? So what a lot of physicians are afraid to say, a kid with a headache that's been 2 years long from a concussion is developing chronic encephalopathy, okay? Chronic traumatic encephalopathy. So that means that there's chronic inflammation in the brain that's going on that's going to continue to affect that brain system. So when I say to you that the headache is the most important part, because you need to cool that inflammation down before you start to get an improvement in brain function. Because you have hypersensitized microglia, you have a drain on the energy systems of the nerves through the mitochondria. Mitochondria is the powerhouse of the nerve, okay? Mitochondria is the only organelle that has its own DNA. So they can come back in a big way. And so when you look at metabolic testing, what we're going to be looking at is really how are the mitochondria in the brain working? How are the powerhouses stabilizing those nerves? Because they're the organelle that directs the repair process throughout a nerve. Because nerves suck energy. Nerves want energy, okay? So by looking at it nutritionally, you know, everybody's like, well, nutrition is based on all wives' tales, right? Take vitamin C for this, take this or that. But today, in today's research and today's science, we can look at nutrition specifically for each individual. So what we use is what's called organic acids, measure organic acids in the urine, and that gives us an idea of how certain pathways are working, whether it's detoxification, antioxidants, neurotransmitters. We look at the Krebs cycle, we look at B vitamins, we look at fat, carbohydrate, and protein metabolism. We look at bacteria, we look at yeast fungal forms. We see the whole metabolic patterns that we can see through organic acids. Then we look at food sensitivities. A lot of times when someone has a brain injury, their gut becomes leaky, their gut becomes inflamed. Because there's a relationship between gut and brain, the blood-brain barrier. So if the gut is leaky, what happens is the blood-brain barrier becomes leaky. So we have to desensitize the gut to desensitize the brain also. And then the last thing that we look at is we look at amino acid utilization. How are they using amino acids as building blocks to enzyme systems, to membranes, and so forth. So those are the three things that we look at primarily. We do have additional testing that we can do. And since the midbrain is affected, the midbrain is about sleep cycles, arousals, and so forth. So we can look at cortisol activity, DHEA, we look at DHEA, we look at cortisol activity throughout the day to see if they're either too high or too low. That can be an effect of headache also, because if the cortisol high, it means the inflammation is high. We need to cool cortisol. We can look at red blood cell fatty acids, and we can look at the relationship between omega-3s and saturated fats. With that test, it's amazing some of the things that I've treated over the years, like optic migraines. The kid was losing his sight. The key test that we did was the fatty acid ratios, and he had saturated fat was 36 times his omega-3s, which is really inflammatory. We changed the ratio, and his sight came back. What was happening? The inflammation was causing vasoconstriction in the brain, in the areas of the brain which he saw. And once that vasoconstriction went away, and his blood flow was proper to those areas, and he saw again. Okay? No big miracle, just basic nutritional science that we use in that case. We also have the ability now to look at hypersensitivity issues around foods. We can look at autoimmunity. Has autoimmunity developed? So with the long-term concussion, with headache and inflammation, we may want to look at, is your body attacking its own nervous system? And if it is, there are protocols that we can use to cool that inflammatory process together. So microglial hypersensitivity is really real. Some of the things that they've done with epileptic seizures and epilepsy with different areas of inflammation in the brain is they've looked at ketogenic diets, high-fat diets, low-carb diets, that type of thing. We've started to use in the office the paleo diet, and the paleo diet is basically protein, fruits, and vegetables. Take out all the carbs, take all the pastas and everything out, and just concentrate on that. And we've just had marvelous effect with our students that use those types of things. So we're going to look at each individual. We're going to add the tests that we think that we need to know, and the information that we need to know to get them to a better spot. Okay, and that's basically how we do it. It's probably the best work I've ever done in my entire life. It's like the coolest thing to see hopeless cases come back.
But the assessment's the starting point, right?
What's that?
The assessment is the starting point?
The assessment is the starting point. Get an assessment. Let's take a look at it. Now, if we get an assessment and I don't think I can do anything with it, then I can't do anything with it. But we haven't found one yet. There's always ways to skin a cat, right? Don't you think? And although my staff doesn't want to take some cases, we've been really successful with every single one. We found a way in which we're going to get a response. Now, we may not get 100% of our goal, okay, but we may get 80% of our goal. And to me, 80% is a marvelous gift, okay? And then the trajectory for change changes, okay? So once you have improvement never stops in the nervous system. when you can't get improvement, then that's the time you say, I don't know what to do, okay? But if you can start getting step-by-step improvements, then what's going to happen is over time, you're going to get closer and closer to normalization where they were before. Jill Moulty-Taylor was a neuroscientist who had a hemorrhagic stroke and completely rehabilitated herself. And when you see her on TED Talk do her presentation, it blows you away that she lost most of her brain, but yet had it come back. When I take my traumatic brain injury course and we do MRI studies of the brain and we see areas of chronic traumatic encephalopathy that has changed the tissue, brain tissue, and then see the whole circulation come back to those areas just by doing eye exercises, it just blows you away. The brain is very plastic, and since the brain is plastic, that means that the brain can come back if it's directed the right way. Any questions?
I do, but I think I prefer the